Good evening, everyone, and a warm welcome to this sixth in the series of events in conversations with nursing pioneers. My name is Professor Daniel Kelly, and I'm the convener of the RCN Fellows, and it's a great pleasure to welcome you all to the meeting, whether you're with us tonight during the recording or subsequently via the RCN Fellows webpage. So we hope that you will find this an interesting and useful conversation with three of our RCN Fellows. Nurses have blazed a trail in many aspects of healthcare, as we know, but tonight's event brings together three RCN Fellows who will be discussing the opportunities that are afforded by increasing digital and artificial intelligence technologies in today's healthcare systems. The event will be chaired by Helen Balsdon, who's the National Chief Nursing Information Officer for NHS England. And I'm just going to say a few words about Helen before we start. So Helen has a range of responsibilities and provides nursing leadership across the country in digital health. Her portfolio includes digital nursing and midwifery, digital clinical safety, and clinical leadership to national digital programs, including single patient record and frontline digitization and productivity. Her own clinical background was in hematology nursing and in oncology. She's a visiting professor in the Faculty of Health, Medicine and Social Care at Anglia Ruskin University. Just in terms of housekeeping, we've asked you to use the Q&A function this evening if you do have any questions or comments. There will be time towards the end to interact with our speakers, but in the meantime, I would introduce you to Helen and invite her to take the floor. Thank you, Helen.
Thank you so much for that introduction. I'm delighted to be here this evening, and I'm hoping you get a lot out of this conversation that we're about to have. As you've just heard, I'm the Chief Nursing Information Officer at NHS England, and that role means I get involved and see some amazing stuff around the country of what people are doing as we are going on a digital journey and stepping into the future. There's lots that digital needs to do to help us really make that change. But I'm always struck by the comment that digital is the how. It most definitely is not the why. And that still comes down to us as professional leaders to determine what is the right thing to do and use our professional judgment. I am delighted to be welcomed by three amazing nurses this evening, all of which are eminent professors in their field. Professor Roxanne Crosby-Nwaobi, Professor Bridie Kent, and Professor David Thompson. I'm going to let them all introduce themselves and tell you a little bit about themselves, but also tell us how they're connected to digital nursing and what that means to them. So I'm going to first pass over to David.
Thanks, Helen. Welcome, everybody. First of all, I should say I'm not an expert in digital health, but I can see the potential and I do use it in the care that I provide. My background is in cardiac nursing. I've been a professor since 1994 at universities in the UK, Canada, Australia and Hong Kong. Before that, I spent 12 years in cardiac care, and that's been my area of interest ever since. I'm particularly interested in rehabilitation and prevention, particularly in the area of psychosocial interventions and outcomes. I was made a fellow of the Royal College of Nursing in 1992 for the work I'd done in cardiac care. And I'm still actively involved in cardiovascular care, mainly through collaborations across the UK and Australia and Hong Kong, but also with other disciplines as well as nursing. In terms of digital health, I'm quite interested, particularly in prevention and rehabilitation, and I can see the potential of digital health for remote monitoring, for example, or for delivering cardiac rehabilitation, which I think is a Cinderella service that never gets the recognition that it deserves. And I can see the potential there with digital health technology and AI. And also in heart failure, and I've been doing some work in heart failure in the UK and Australia, where we're dealing with rural or remote populations. So digital health has a great potential and impact in healthcare there. So I think that's enough from here, Helen.
Fabulous. Thank you very much for that.
So my name is Professor Roxanne Crosby-Nwaobi. I'm a Professor of Ophthalmic Health and Care at Moorfields Eye Hospital and the UCL Institute of Ophthalmology. I also have a role as the lead nurse for research at Moorfields and my program director for senior research Ludo at the NIHR Nursing and Midwifery Office. In terms of digital, I kind of got involved during the COVID years when I was on a 70 at 70 NIHR fellowship for nurses and midwives. And at that time, we developed an online platform called Roam, Research Opportunities at Moorfields, which allowed patients nationally and internationally to have a look at what trials we got going on at Moorfields and to feel free to get involved either as contributors to the design of the research studies or as participants to the studies themselves. We then later moved on but that program called Roam won a Nursing Time Awards back in 2022. The following year, we also won another award, the Nursing Time Digital Award for an innovation called MedMemo, looking at medication optimization. But generally, working in the ophthalmic space, it's so exciting to be part of the new digital frontier and AI as well. Because as we know, ophthalmology is the busiest outpatient specialty in the UK, with over 500,000 operations per year, which is about 6% of the NHS total. And there's over 7.5 million outpatient appointments. So we need to do something. And I happen to work with a fabulous team led by Professor Pierce Keane. He's a professor of AI at medical technology. And back in 2015, he negotiated a collaboration with Google DeepMind, which allowed us to have a look at linking images to data and to determine what the eyes, looking in the back of the eyes, can produce. And since then, we've got other members of the team who've created platforms, like one is called AllsEye, which links retinal images to systemic data, and then the field of oculomics was born. So potentially, if we can link our optician visits to our annual GP visits after the age of 40, we will be able to predict and monitor people's systemic health, because we've been able to show differences up to 7 years in advance and diagnose people's risk of Parkinson's up to 7 years in advance, because we've been able to see symptoms in the eye. So I'm really excited to be part of the ophthalmology field and leading the way, I guess, in this.
And your passion absolutely comes across. Thank you. Bridie, have we sorted the tech out?
I think we have. Is that better?
Excellent. That is wonderful. It's always great when it works well, isn't it?
Absolutely true. So yeah, nice to meet you. My background is in critical care nursing, and I suppose that was where I first got involved in the digital world, because I started off with paper and pencil, and paper and pens, and things have moved on significantly now. And so yeah, I got involved then. And then when I was in Australia, I worked very closely with a tech firm because they approached us to find out about. They got some they got some ideas that they said this is a way in which we can pick up on care that that nurses aren't delivering. And it was a case of getting the technology people to say, hang on a minute, let's step back a bit, let's us get involved, and let's try and make sense of what you're talking about. So we worked with a company that became known as Smart Ward, and we did some trials looking at again getting technology into clinical areas, and this was what 16 years ago. So, significant period away. But now we're seeing technology coming in. So I work at the University of Plymouth, but in my other days of the work, because I'm trying to retire and failing miserably, I'm a non-exec director on the board at the Royal Devon Hospital, and they were one of the large trusts to bring in a patient patient electronic record system called Epic. And so although I'm not directly involved, I'm on the steering committee because that's now being rolled out across the rest of Devon. And so it's really interesting to see sort of, the benefit, just how much technology can make a real difference to not just the staff in the hospital, but it's the way the care is delivered, but also the way people receive care. And it's blown away some myths and misconceptions. So that's probably enough about me, Helen.
Brilliant. And you all bring so much to the table in terms of that experience over many years. So I'm excited to see where this conversation takes us. And, I guess my first question, I'm going to start with you, Bridie, is in your experience of digital transformation, which clearly you've seen it over many years, what are the key skills that we need to equip our workforce to really make sure we harness the technology so that we can continue to make great improvements to care?
I think one of the things that we need to do is have courage, because it's easy to dismiss technology, and it's easy to think, oh, it's not going to work, or so it's easy to come up with all the problems and all the negatives. And actually, it's having that openness, having that courage to say, come on, let's have a look. Is this going to be a viable way of doing things differently? So it's being open to change, being willing to change. And all my research career, that's the thing I've been looking at, is how do we get changes implemented into practice? And change is one of the things that people really don't like doing. And it's not just us as nurses or other health professionals, it's members of the public as well. It's the people we care for. We like things as they are.
Yeah, totally. And change is a constant when you work in health, isn't it? David, what about you? What are your thoughts on that?
Yeah, I would agree with Bridie. I think people are frightened of new things, and particularly technology, because I think nurses particularly, but also all health professionals, are sort of wary and threatened by the impact it might have on their lives. And I think it's persuading them of what the potential benefits could be, particularly in terms of patient care and health outcomes. And so I think persuasion is an important thing. I think incentives to using it, trying to overcome and identify and overcome barriers to using it. So I think once nurses can see the potential and the benefits of a new technology, I think they're quite receptive to using it. But they also need to bolster their confidence. So I think they need training, support, particularly peer support, I would argue, and working with people who are more experienced in using technology. I think those sorts of things can help a lot. As I said earlier, I'm not an expert in this field, but I became persuaded about the benefits of this technology and have tried to embrace it, but realize that there are obstacles as well.
Absolutely. And you've all talked about the human element. Roxanne, what about your perspectives?
Hi, Helen, thanks. So I've kind of broken it down into three things really. So A, how to access. B, what I call make it make sense. Because you've got all these numbers flying around, what do I actually do with it? What does it actually mean? How does it actually apply to my patients? And then the last bit, which I guess is more down my end with the audit and improvement cycle. So now it's making sense. How do I improve on the parameters that are actually there? How do I make it more sensitive? How do I make it more applicable to a diverse range of patients? So that's the kind of things I tend to look at when thinking about our workforce and technology.
Absolutely. And you've all described the human elements. And from a digital transformation lens, you have to align the people, the way in which they work with the technology. And there's international evidence that backs me up on this, it'll fail. And we've seen more failure than we have success across the world in this space. And I think that improvement piece absolutely comes in. But the systems have got to add value to what we do and be usable. So that we really can drive those improvements. But that human element, we should never forget. It's interesting, we hear lots about the tech, not about actually the humans that are going to use it. So I'm delighted that you've called those things out, because they are core skills. And that confidence, David, absolutely. It's not just competence, it is confidence. And sometimes having just somebody at your elbow that just go, what do you do normally? And just talk you through it is all you need to actually see the potential. So, some great points in there. But, there is lots of tech, and everybody's talking about the tech that's out on the market. We were talking the other day in my world about the new piece that's the bright and shiny, which is ambient voice technology. And there is over 118 different suppliers in that market. And that's just one piece of technology. So it's vast in terms of what's out there. But the potential is also vast, and it's something we shouldn't miss out on. But curious to know what tech solutions that you've seen that you think actually that could make a real difference to the way in which nurses practice and lead as we step into that digital environments that are going to be part and parcel of what we do. David, I'm going to start with you on that one.
Okay. Well, I've been involved in a project. I'm based at Queen's University in Belfast, and I've been involved in a European-wide project funded by the EU to develop an avatar to deliver heart failure care. And so this has been an experience. It's been going on for a few years. But we've been working a collaboration across 4 countries, nurses, cardiologists, pharmacologists, users, patients and relatives, and also predominantly tech people, different companies who have been working together, sometimes not working very collaboratively because obviously there are IP issues and all these sorts of things. But it's been a great learning experience for me. And the idea is that this avatar, which we call Dr. Me, works on algorithms that have been developed from clinical standards, from evidence-based guidelines, and it prescribes treatments to patients based on an assessment of their clinical profile and their needs. Now, it's only in early stages, but it's going to be trialed across the 4 countries. It's taken a while to develop it, but I can see the potential there for heart failure, because heart failure is an epidemic in cardiovascular disease. Nurses are at the fore in often delivering heart failure care management, often in the community, and particularly to older people, often socially isolated. So I can see the benefits to nurses for that, and we've written about that, how nurses could embrace this and how it would release them to do other things, and what the benefit, trying to persuade them what the benefits are to nurses as well as to patients and their caregivers. So that's an example. Another example is I've been working with a student of mine to develop an app to reduce the risk of cardiovascular disease in taxi drivers. A taxi driver is a notoriously high risk of heart disease because they sit in taxis all day. They tend to eat burgers and drink lots of coffee, tea, maybe alcohol, I'm not sure. But generally an unhealthy lifestyle. They don't do much activity. Now,
Actually, not drinking while they're driving.
No, I hope not. And I'm generalizing grossly here, but that's the typical profile. So we've been trying to change their lifestyle through an app that we've developed with taxi drivers. So it was a co-designed app, and we've been trialing that. So that's a couple of examples of how we've tried to use technology, digital technology and AI.
I was on mute then, sorry. You know, I hear the potential in your voice and the excitement that's there, and actually loving the fact that you're talking about teamwork with different professions as well as the public and people who are going to use it. And I think that's so important. Roxanne, what about yourself?
Yeah, thanks, Helen. So again, ophthalmology is the most exciting profession, and I'm going to die on that hill. So we've done, lots of great things. So like right now, just came back from Singapore with a team of 6 medical students. We joined this team called the Reach Alliance, which enables student researchers. And these ladies were looking at data sharing, because it's all well and good having the tech there, but if patients are reluctant to share their data, we're in a highway to nowhere. So they were able to speak to 3 communities, looking at faith as the driver, because we know that in London anyway, over 70% of our patients or people within London subscribe to a faith. So therefore, and faith is also a lens by which through people, make their healthcare decisions. So does faith have any bearing on their decisions to share their data? And some evidence shows that it actually does. But ultimately, the patients were more about altruism. And if we can be transparent, looking at historical factors and reassure them that their data is going to be safe, is going to be used appropriately, they're happy to do that. So that was one project. Another project that I'm working on with another community group, and again, an underserved community group, which is really my area, is enabling lay people, individuals, to understand their data and to use that health data to improve their health outcomes. So we've written up this grant looking at Bollywood dancing. Some communities do that as a way of just integrating and having a great time. And it's very taxing on the heart and the legs. But then people, go away and don't do anything else after that. But if we can attach a Fitbit to their arms and show that an increased heart rate, helps with your blood pressure, overall control, helps with, calorie count and everything else, then they're able to actively use that health data to improve their own health outcomes. So fingers crossed that gets funded. And then something else we're doing more related to the eye world is looking at automated AI. So we know that back in 2016 and 2018 and 2020, we had the first and the second ever automated AI system for analyzing and diagnosing diabetic retinopathy, which has FDA approval. And that's supremely important because we have a diabetes pandemic. We're going to have over 585 or 87 million people across the world with diabetes by 2030. And obviously, we're going to have these complications. We know currently diabetes complications account for about 10% of the NHS budget. So we've got all these people coming with diabetes. We need some way of looking after their eyes. Yes, we need to concentrate on the prevention, long-term management, metabolic control. But if they do have complications, who's going to read all these images? So that's just 3 examples that I've seen recently.
Whoa. You can see that revolutionizing, and it's really interesting. There's lots of hype around AI, but actually what you've described are initiatives that really could make that difference, and really, really interesting. It does depend on quality data though, doesn't it? And actually we know we write lots of narrative. Does it always mean very much? And the work I've done is lots about how do we document care? Actually, when do we document narrative? When do we document structured data? Probably need both, but we document more than any other clinical profession. But if we're going to develop AI algorithms, we've got to be really clear about the data we're doing. It's got to be of a high quality. So it's got real potential though. And some of that is amazing. Totally. Bridie, same question to you.
It's interesting what Roxy was talking about with Fitbits, because David thinks I'm bonkers, but I'm one of these mad runners, and we're using I wear a smartwatch, and actually what we're finding in the clinical setting is how much wearable devices can be useful. So patients who are out, you can see from my picture, I live in a rural area. And we haven't got good internet, we haven't got good technology, but actually you can use wearable devices that can actually record things, can really capture information. One of my PhD students who's got her graduation on Monday, Amy Emmett, Dr. Amy Emmett, she has been looking at using Cardiomobile and some of the devices to record AF. There are other devices now on the market other than Cardio, but she was really interested in how do nurses use these sorts of technology out in the rural areas and the benefits it can bring. And it all came about because she couldn't get patients into the GP surgery or into other areas to actually have an ECG done. So it was a lot easier to take things out, but she couldn't take a big ECG machine. Whereas these are portable devices that have transformed the stroke. It's picked up people who have AF who could then go on to have a stroke. So how many people has it prevented from going into a stroke that's having all of those complications further down the line? I'm currently working on a project in the Philippines at the moment, and you think, could some of that technology help over there? The biggest problem is cost, and it's how do we get some of this technology in? Because we know it makes a difference, but we've got to balance that up against the the cost challenges that we've got at the moment. I mentioned when I was an ICU nurse. Well, when COVID hit, I went back into clinical practice, and I had to really go on a steep learning curve about technology at that particular time, because, like I said, I was used to paper. When I worked in ICU, I was used to paper charts. I was one of the dinosaurs. Actually, it was probably they were thinking it could come in useful when we ran out of technology. But most of the time I was I had to really learn how to use the new technologies that are around today to document care, as you've just said, get that accurate data in. But then we've got all of you then need people to analyze the data. Whereas now, if you've got really good AI systems, you can have that working behind the scenes and start to take some of that load off. So, it can work in so many different ways. I mentioned Epic. And it wasn't easy it's not been easy to implement, mainly because of the complexity. It's a complex system. But actually, when you look and see just what it can do and how much difference it makes from a record keeping point of view, having things in one place, being able to see data that's that other people have inputted, rather than sifting through the old way in piles of notes, information gets lost. And it means that patients can be much more empowered as well, because they can see the data. They can have information, have much more control around what they do when they attend outpatient appointments, a whole range of different things. And it's all due to technology. When you think we're using technology today, when you think we've got so used to using Zoom or Teams and things like. And even during the COVID pandemic, I remember in, many patients in ICU, we couldn't have relatives in. Technology, with that communication technology, was vital. Most people had never used iPads and things like that, or tablets for communicating in those circumstances. But it's amazing how quickly we learned, and just the benefits that brought.
Totally. It's all in our hands these days, isn't it? That's where it's at, and that's our reality. And what you say resonates. I think when I was rolling out a patient portal, happens to be in the same electronic patient record that you were using, actually the best thing we did was give it to the staff, because if the staff were confident with it, comes back to David's point earlier, they promoted it to people to help manage their healthcare, and it's really powerful. But I think we forget the power of a mobile phone. Most households have, I think it's something like 98% of households have a phone. Now, clearly that doesn't mean everybody in the house has one, which is quite different. But in rural areas, they can really make a difference. If you're miles from healthcare, actually, as you say, picking up your heart rhythm in a mobile phone, there's lots of opportunities to go, is this something I should be worried about? Should I get somewhere? Could completely revolutionize what we do. Yeah, really, really interesting. If I was going to
when I'm out running on Dartmoor and decided to do a trip up and face plant, my watch will automatically then alert, you know, my husband at that point, you know, to say there's a problem. But that could easily be utilized in so many different ways, you know.
Yeah.
And I'm, you know, as we get used to technology, we can just adapt it to make it work for various situations. If somebody has a fall or something like that, you know, having that being able to have those calls made without somebody instigating a button, you know.
Yeah.
Yeah, it's lots of possibilities.
It's how we take people with us on that journey, isn't it? If I was going to suggest a technology, and clearly there's other brands around, but I think that Copilot one has made a difference. You know, I remember when I was a matron, I didn't have admin support. So managing my diary, the amount of emails that I had when I was out on wards, actually made it really hard, you know, chairing minutes and writing up all the stuff. Tools like that can actually support, not necessarily with direct clinical care, but actually those functions that go on in the background to help you be, I guess the language is personal productivity. You know, we forget them, and we're all still learning, I think, but it's tools like that that can really help us.
In the trust, we've got, like, we've bought some licenses in the trust to give it a try, because, you know, we've got to do things differently. We can't keep doing things in the way that we've always done it. And I'm not, you know, I'm a novice with Copilot, but it's amazing the things that it can do. And it's learning how to give it good information so you get the most out of it.
Yeah, asking those great questions, which actually nurses generally really curious, but it's how you translate that into the written word to type it in. I'm still learning and got lots to do. But while I've got you here, I'm going to ask you that next question that I've got is, technology alone is not going to solve our problems. You know, what else do we need to consider as we make the shift to a digital era?
I think we've got to remember that it's not going to do away with people. It's not going to do away with our expertise. And I think that's one of the fears that people have got, thinking, oh, you know, we're just going to be electronic nurses from, you know, sort of remote nurses from now on. No, we're not. It's only as good as the information it gets, and it gets it wrong. And so it's really important that we understand the limitations of digital, the limitations of AI, and many of the other things, so that we know what are the boundaries, where is it good, where is it not so good, and what do we need to do, particularly for things like check, you know. But you mentioned Copilot, it can do minutes, that's really good, but somebody's got to check it, because it can make it up. So I think we need to be aware that, you know, be very much aware of the you know, the technology, be aware also that I suppose there's the concern about digital literacy, and that some groups of the population will be marginalized by this. We've got to also be careful of not assuming that because you're elderly, or because you're in X, what we put people into boxes, don't we? And it's always going to be the case. You know, I've got some elderly neighbours who are really good with technology, so I think we've got to be aware of the fact that there are some groups that could be marginalised, and what do we need to do to accommodate that, or to tailor it to, you know, to help them to adjust to that, you know, make adjustments in that digital world.
That is so true, so true. And I've actually seen some of those people that struggled with face-to-face services adapt better to digital services. You know, I remember my hematology pass maybe coming through, but, you know, somebody who had autism, and he struggled with face-to-face interactions, and we gave him access to the portal. And the clinician said, I've never had such great conversations with this gentleman, and they're all written. And it's because that was his preferred way of communicating, and they got far more out of them. So it is trying to find the right route that suits the right person. But I think we're at a generational change, because we've got a lot of people that they still want the face-to-face, coming back to it's hard to change, but actually so do our clinical teams want face-to-face. So it's about people, isn't it? And we've got to adjust and recognize the technology can help us personalize. And digital isn't always first.
And it's not one size fits all either.
No, absolutely, absolutely. Roxanne, what would be your thoughts on that? What else do we need to consider?
Yeah, I think it's coming back to the person because person operating this at the end of the day. So I would ask for when designing all of these digital technologies and these AI algorithms, so that
Don't know if it's just me, but I keep losing Roxanne.
can you hear me now?
Yep,
You
you keep coming and going.
Oh, apologies. Okay, go to David first.
Go to David. Okay, David, what would be your thoughts?
Well, I think like Bridie was sort of implying, I think digital technologies and AI, they're there to enhance and augment care. They're not a replacement. So I think that's an important thing. I think digital health literacy is important. I think health equity is a very important factor in all this, because we know there is discrimination, bias, these sorts of inequities that go on, often unconsciously, but they're there. And so I think we need to know who the target audience is, and maybe we need to segment these technologies and target particular groups who are hard to reach. I think there's also ethical issues, about using these technologies because we're at an early stage, really, of their development. And it's a rapidly evolving field. So I think patients and staff, including nurses, are sometimes cautious about, how safe is this data? How is it being used? How reliable is the data? These sorts of issues, I think, have probably not been addressed as well as they should be. I've worked with an anthropologist who, again, we have these myths about who uses these technologies. And often I hear from colleagues that, older people or certain groups of people will not like using mobile phones or technology. But actually, working with this anthropologist in London, his view is that elderly people are very attuned to using technology. They're often better at it than we suppose. So I think there are lots of issues, human issues, ethical issues, societal issues. As Bridie talked about in relation to the Philippines, I do a lot of work in Thailand, and we know that resources are a real problem there, but also cultural issues and beliefs. Some people are wary of technology because of beliefs that they have about technology. When I lived in Hong Kong, I worked a lot with people who use traditional Chinese medicine, but are very wary of using Western medicine, including imaging and technology. So I think we've got to be cognizant of that.
Yeah, so many things, and it comes down to how does technology personalize? So we give the right
Exactly.
care to the right person at the right time in the way in which they want to receive it.
Exactly. So I think choice and preference are really important, and they're involved in applying this technology and using it, deciding which is best for them. So I think that will increase uptake and usage, and so on, and probably improve outcomes
Yeah,
using
yeah.
these technologies.
No, I totally agree. And the human should never be out of that loop, isn't it? We're a caring profession,
Yeah,
and it is that piece of how it supports us to do the right thing.
exactly.
Thank you. Roxanne, is your technology working?
I think we're back on.
Excellent.
So just to touch on the points that the other presenters spoke about, ethics, but I think we also need to speak about professional responsibility. How does our NNC code of conduct relate to the new age and what we're doing? So we've got these new, lovely, young, most of us, and other individuals who are having to use this technology, but do we understand the ethics behind it? If we do, say, for example, have an AI suggestion on a treatment pathway, who has the ultimate ethical and legal responsibility for that decision? How are we training our nurses on this? David spoke about digital justice or equity, people who are from the underserved communities, low digital literacy. But I think something I will touch on is interoperability, really. We've got the NHS Federated Data Platform, great thing, but who's actually using it? And what are we using it for? How are our patients involved in asking the research questions behind what needs to come out of such a platform? Who is informing what's coming out of it? Are our nurses involved in looking at the interoperability between our ecosystems and getting the data out of it? So, yes, it's there, great, but how are they able to make sense of that data and use that data themselves to further their patient care? I think that's the kind of things I would like to see us do in digital workspace.
Yeah, you've all come up with such diverse things, and in terms of that data, and it's only as good as is it useful, usable, and is it going to be used? And I think, we see lots of different environments for collecting data, but there's something about, are we collecting the right information? That's not just data, is it? Sometimes you need that observational piece as well, the right information that helps us make the right decisions, or indeed drive the right improvements to care. And I think how we do it is going to become increasingly complicated, certainly in England, as we start joining up records and moving down the routes of developing routes that look across, which is creating a single patient record, interoperability. But it has its pros as well as its cons, but it's about understanding and awareness. And I think it's that knowledge base that really does need to increase, so we understand our role and our boundaries, as you rightly say, responsibilities and accountabilities. I was talking to some colleagues in the US recently, and they were going, some of their debates is, can the chatbot prescribe? And they were trying to work through, where is the responsibility of the clinician? Who's making the decision? How do you check the algorithms behind the chatbot? Really interesting. And I can see us needing so many of those conversations in the years ahead, because we don't know what techniques are going to be around in 5 years, let alone 15. So actually being able to understand data, improvement science, and actually use that curious inquiry to really explore ethics and understand boundaries to care. What does that mean? What does it mean for the person? I think are going to be skills that absolutely are upon us, but we need to make sure we bring through. It's really interesting. I'm looking at a couple of the questions that are in the chat, and one of them is about, I guess the next future generation of nurses and midwives that are coming through, as opposed to the whole workforce. How do we make sure everybody is equipped with all of this, the knowledge and skills, but giving them the experience and the exposure to work in a digital landscape? Because we often think about, we need to add it to curricula for nurses in training, but then we forget the majority of people who are already in training. And I remember myself asking the questions, does your School of Nursing teach care planning? And, as we were trying to roll out some digital tooling, and it was like, well, yes, of course we do. And it's like, oh, they don't use it when they're in practice. And they went, no, because none of your nurses do. It's like, oh, okay. And you start looking at, you need both, but that's a tough act. How do we address all of the workforce, both what we have now as well as the future? It's a loaded question, but really curious about your ideas, Roxanne. What are you thinking?
So the first thing I'm thinking about is training. And then, you did mention across the lifespan of the nurse. But even before we get to undergraduate nursing, what are we doing in our schools? So from primary school, my daughter just said to me last night, and she's 10 years old, I don't know how you survived without a mobile phone. I'm like, excuse you? But that's her life, and then my mom then sent me a message and said, I just discovered ChatGPT, oh my God, how it's so amazing. So literally within 12 hours, I've had these two completely ends of the spectrum in terms of age appreciating technology. So how are we training our young and our elderly and everybody in between to come along on a journey with us? Somebody in the chat spoke about, exacerbating health inequalities. Yes, that's definitely a risk. But again, how are we upskilling, updating everyone that we come into contact to? So I know, for example, with Moorfields, we discovered, surprise, surprise, that there was some staff who were not able to access emails. It isn't that the email address wasn't provided. It isn't that some training weren't given at induction. They just weren't able to navigate the system. And we've got individuals like that working in our healthcare systems. So now we've did some basic training in-house, but we've got a continuous program where all staff come in, get digital skills assessed, and they're given training with the mandatory training to upskill them in one area. If that can happen in an institution where we are seen to be, ahead of the game in terms of AI and digital, it can happen anywhere. So for me, training is key across the lifespan.
Thank you. And I love that example of, assessing somebody's digital literacy and actually equipping them, because we take it for granted everybody can use an email now. But I think you're right. That I love that. Absolutely. Bridie, I can see you nodding away. What are you thinking when I ask that question?
I suppose the thing that comes to mind for me is we can't forget about evaluation. So we're really, in the NHS, we've done it for years. We're really good at saying, oh yeah, new technology, we put this in, and then go, oh, it doesn't work, but without actually trying to find out why it doesn't work, or just trying to find the less, what are the good things? Why does something work? And so I think I think what we need to do is have a really structured evaluation program, and it picks up on the point that I think Dallas Carter's put in the chat about making sure that areas of deprivation aren't left behind. Where if we can evaluate, who's using things, where it's working, getting patient feedback, getting user feedback. Having that user voice in the system, whether it's a clinician voice or it's it's one of the people that are using the services. So I think for me, evaluation is really, really important, because we can learn, but we have to learn the lessons from it as well. We've got to know what's worked well, but also if things haven't worked so well, why not? Understanding why not, and what were the reasons for that, rather than just dismissing it.
No, I think that's so true. And a lot of what I'm seeing lately is about improvement science and how do you use that? So, because it doesn't work everywhere, but actually that understanding the problem you're trying to solve, looking at the intervention, but looking at what the impact of that is. And, there's a rigor in there. It's not necessarily your academic research piece, but that's in a world where technology really moves, that might be a route that we really do need to maximize. So we make sure we get the true evaluation, that we understand it, and keep building, because you can't just go, oh, it doesn't work, and switch it off, can you? It's an evolution.
It takes time, and I appreciate that, we've got to, we're moving, things are moving very, very fast. But I think we do, there are things where we, particularly where it's new, that we need to be able to just, take that time and really understand and invest in that, so that we don't make mistakes. We've got to learn from some of the things that that we've implemented years ago, and so we don't learn, don't have repeat lessons.
Absolutely. David, what are your thoughts?
I mean, we often reinvent the wheel, and I think there are lots of frameworks that we could use, to look at this. I mean, I think back to, I'm older than I think everybody here, and when I was training, we were using things like Don Obedience framework, structured process outcome, and these are sorts of frameworks I think that we could use in with digital health technologies. What are we hoping to accomplish by using it? What is it that we're trying to achieve? Are we better focusing on one or two key things rather than lots of things? So I'm thinking in terms, for example, preventative medicine or chronic disease management. They're two major crisis facing the NHS, for example. So I think using those sorts of approaches could be very helpful. The other view I have is thinking wider than nursing or the health professions. You know, I think nursing and medicine, for example, and allied health professions have sort of trained and educated in silos. And I've, for many years, thought we should be doing joint teaching and education with medical students, nursing students, allied health students, right from the beginning, so that there's a commonality about what they're all learning and how, for example, they could use digital health technologies. So, and I think that would break down a lot of barriers when we're talking about things like collaborative care. So I think we've got to be much more creative about how we go about using these technologies.
I think that's so true. You know, when I did my cancer care degree, it was a multidisciplinary degree. There were common themes across it, and then you learn what was relevant to your profession, because there'll always be those professional nuances.
Of course.
Absolutely. But actually, maybe it might help people understand. I think we understand each other, because we don't always understand, do we? No, it's really interesting. One of the other questions that's in the chat is, I guess, really about, Janet Michaels has just talked about, they're moving on in the US. They're probably 15 years ahead of where England is, absolutely, in their technology. And they're seeing some of the constraints in the big electronic patient records that have been put in, but really looking at how do we, and I guess it's that data from lots of different models, because our data doesn't just come from somebody's health record, does it? Even if it's joined up, it comes from lots of different places, and in the UK at the moment, we've got a hospital record, a primary care record, a mental health record, a community record, and not all of it's joined up. But if we're making improvements, we might want experience data or patient safety data, and they all sit in different siloed pockets. How do we bring different bits of data together so that we can unpick some of these? How do we think we need to approach it and make sure that our profession is equipped to data share? Coming back to your earlier point. David, do you want to take a stab at that one? Does anybody want to drop in? It's a big one, isn't it?
It's a big one, yeah. I mean, I think that I'm not being anti-American here, but I think there is a myth that America's way ahead. I mean, the States vary so widely. I do a lot of work with different people in the States, and I think under the current government, there are lots of challenges going to face the use of technology, and even the nurses' role, where nurses are being devalued in certain states. For example, nurses not allowed to call themselves doctor after they've done a PhD. These sorts of debates are going on. So anyway, that's probably being a bit parochial. But I think it's difficult. I mean, one of the key people in digital health, AI in healthcare, is Eric Topol. Now, Eric Topol is an American cardiologist. And he runs, I think it's the Topol Digital Fellowship.
The digital doctor is his book.
Exactly. So I think people like him, we could learn a lot from, and different models that have been used internationally, and in different fields, different disciplines. I'm being a bit vague here because it's.
But I think, it's a big, tricky issue. We use data from so many points, and there's something about how do we take the best from the different countries around the world? Because I get your point. That's just one healthcare system. I think Australia's.
Yeah, Australia. I would say Australia and Canada, for example, would be good models to discuss these sorts of issues with and learn from them, rather than reinventing the wheel all the time. Often the solutions available elsewhere.
Yeah. And maybe federated platforms that help us bring the data together.
I mean, Hong Kong, which I'm most familiar with, is a very digital country, or part of China. And there's lots to learn from it. But as I said, there are also cultural issues. A lot of people are against Western medicine, for example, or healthcare, and they go for traditional Chinese medicine. So there are all these sorts of nuances
Yeah.
around.
I think it's sometimes about how do we get their learning, get their big brains looking at
Yeah.
what they're doing, but equally understand each other's
Yeah.
context, so we can take that bit won't work and isn't applicable, but that bit
Yeah.
will.
I saw the International Council of Nurses had released a report a year or so ago about digital technologies, and I mean that might be an organisation that we could consult and
Yeah.
find out what's going on across
Yeah.
the globe. I don't know, because I don't know
Yeah.
its people well enough, but
No,
yeah,
there's some good opportunities there because
yeah,
nursing is global. Absolutely. We're sitting people from
exactly.
America here, so it's fabulous. Roxanne, what would be your thoughts? How do we join up the data?
So I've heard some stuff from my colleagues, and I have looked into it myself, but I think a new method that we're trialing at Moorfields certainly is looking at natural language processing.
Mm.
So the unstructured data is structured because, well, it's unstructured because it's not in a particular format, but it's our medical notes. And we're combining that with images and other structured data to predict like patient letters,
Yep.
predict patients' treatment. So that's one way of incorporating the unstructured with the structured. I think where we haven't gotten to so far is our intuition as nurses. It's based on something, but you do have that tricky gut. I think it's going to take a while to be able to, get your gut feeling in there. But again, that's why working with nurses to be able to structure the data and not, bringing us to the table is necessary. Then there's other formats like integrated machine learning. Again, I don't know very much about it, but it's another field that's coming through, as in how can we link our unstructured data with our structured data to produce a more viable outcome than would have gotten before.
I think I think that's so true. And I love the point you've made about intuition, because I think as nurses, we don't always understand it ourselves, do we? Maybe the tech could help us. There's a study in the US, and I'm struggling off the top of my head. So if anybody remembers the name of my US colleagues that are on the call, but it's looking at nursing documentation, and it's showing that it doesn't matter whether they're looking at narrative or structured data. What they're showing is the technology can pick up somebody that's at risk of deterioration before there's any physical symptoms by looking at what nurses have documented about the individual. And maybe that's be interesting to see if it's replicable to the UK or not. Is our practice so very different?
But what I think will be even more interesting, Helen, and I don't know if it's already done this, we know as jobbing nurses on the ward, probably beside Bridie in ICU and critical care, sometimes you do the blood pressure, but you're running around and there might be some delay before you document it. So is that delay crucial in what if we were to put ourselves against, AI, for example, that's predicting when a patient is deteriorating, at what point do we get that sticky gut feeling? Is it the same time that the AI has picked it up and we haven't had time to document it yet? That might be something to look at. Because I'm pretty sure we're pretty good at processing us humans.
Oh, you're making me spark. I'm really thinking of, and just thinking, I talked earlier on about ambient voice technology, so that listening technology. And maybe if that was at the bedside and we talked to the technology and then we use the AI to build that intuition, there might be something in that, mightn't there? Really interesting to see what the future holds and where this is going. We clearly need great brains on this to really see if this is something we can take forward. But so exciting. That's why I do this job. I love that idea. Bridie is the ITU expert in the room. What are your thoughts as we're talking quite radically about changing the way people work?
It's interesting you were saying about talking to things. We've got a research technology or approach called Speak Aloud. It's been shown to be really effective. You see, now could that be adapted to, could those techniques be adapted so that the technology can pick it up? So instead of having to document everything, it's capturing that as we go along. I do think we need more, the thing that you were saying about nurses, that, so that intuition, there's something about I think it's about nurses leading research that is really important, because we don't necessarily fall into that, I know David said about, the education can be siloed, but I think when we're looking at things, we look in a much more holistic way than many of the other disciplines. And so I would really love to see much more nurse-led research in this area, but multidisciplinary research, but led by nursing, because I think that's offers us some really good opportunities. And also, it's about time that the technology companies actually spoke to each other as well. When we were doing this work with Smart Ward, one of the things that they were trying to do was get technology, get this generic technology. I don't really know what it's called, but it's stuff that isn't. It's more behind the scenes stuff where they can connect up with other things. So it's not licensed or patented or whatever by various companies. We've got to have more than that. In Devon and Cornwall, where I am, we've got a real problem looming, where we've got one region, one county using one system and one county using another, that doesn't actually talk to each other. We've got primary care that doesn't talk, as you alluded, primary care that doesn't talk to acute care. We've got to get over that. The technology companies, if we're going to make a difference, the technology companies have actually got to come to the table and start really working together. We work together, but it's got to be on both sides. My feeling is.
I think we've got to get stronger at really setting the standard and being clear. These are our problems. This is the type of technologies we need. What does that look like? And actually, but because I see, and we talked earlier about the different technologies, and nobody had the same ideas or had seen the same things, had they? So there's so much there. But I so often see technology looking for a problem rather than problems looking for technology. And I think that's where I keep coming back to, actually, there's hundreds of different things we can buy. Will it add value to what we do and how we practice? And, really make it, I know I keep saying it, I've said it 3 times already, make it easy to do the right thing, because that's what technology should do. David, you said earlier, it's got to augment and enhance our practice. It's not about doing it for us. There might be some tasks, I'm thinking follow-up conversations after a discharge. The tech and chatbots and avatars might be great at doing some of those to release nurses to do some of the stuff that only a human can do. And I think that's so important, isn't it? And we keep coming back to those human factors. Some of the conversations that, and I'm struck by something you said very early on, David, about the opportunity of prevention. And certainly England has got a new 10-year health plan, which is based on 3 shifts: analog to digital, hospital to community, and illness to prevention. And we're trying to make those shifts, and they are big, but really it starts at prevention, isn't it? We've talked a lot about wearables, prevention. How do we, some questions there about self-care, self-administration, supported administration of medicines, so you're not dependent on healthcare. How do, this is core part of what nurses do, regardless of where they work. But how do we really amplify the nursing voice and use the technology to support people to self-manage? Any examples where you've seen it working, or thoughts on where we start?
Well, I think, it's a major challenge. Although I focus very much in cardiovascular disease, and that's a broad church, but really many people with coronary heart disease also have diabetes. They probably suffer from mental health problems. So actually, 3 of the biggest health problems globally would be mental health, cardiovascular disease, diabetes. And so we need a much more integrative, collaborative approach. And I think it's working with patients. What are the key priorities for you? Because often we judge health outcomes on what we think their health outcome should be. But when you ask patients, their health outcomes often are totally different to the medicalized sort of model that we've been brought up on. So I think maybe prioritizing what are the major health problems that the public or people with diseases or conditions have, and then trying to think of solutions to address those. Nurses are at the fore of management of all these conditions anyway, much of it managed in the community, often in collaboration with their families or caregivers or partners. And so those are the things I think we need to look at and impress upon politicians and policymakers the importance of this, because nurses are very good at advocating for patients, but they're not always very good at lobbying politicians and policymakers, or even more important, the chief financial officer, who's the one with the purse strings. So I think we have to be much more creative and unified in pushing that sort of agenda, and focusing on one or two things, show that they can be delivered, which is always what politicians want and they can take credit for, and then work on the next lot of problems. Now, it's a very simplistic approach, but I'm a fairly simple person, so that's the sort of approach I think I would take anyway.
You know, you're talking about nurses using their voice. I
Yeah.
think it's fabulous.
Yeah.
You know, in that advocacy role. Brilliant. Bridie, I can see you nodding away to some of what David's saying. What's going through your head?
Oh, I just think we need to have a place in the room. You know, we need a place at the table. And I think this is this is an area that if we're not careful, we could get sidelined. And it's not a saving, it's not just because I'm a nurse, it's because of what as nursing we offer to that healthcare system. And I just think we really do need, I think David's right. We've got to learn to be a bit more political, and but we have to be, we have to have a voice at the table.
Definitely. Roxanne?
Thanks, Helen. So we've had this discussion locally within my team, and I guess the answer we kind of came up with is we have to do 3 shifts before the actual 3 shifts as a nursing workforce. First, we need to do a shift in mindset, as we discussed later on. We need to do a shift in our skills, building up our skill set, and then a shift in our care pathways, because our care pathways are not designed currently to undertake or to use those technologies. If I just hark back to the shift in mindset, I know we've all spoken very positively about training our staff, getting them on board, but something I think we didn't really pick up on was staff well-being. In a system where people are losing their jobs, thinking that, tech is taking over, how are we looking after our staff to make sure that they understand, as what David said, is there to augment their roles, not to make them lose their roles? And then bringing them on that journey for confidence and their skills, and then looking at our pathways. Are our nurses at the table? Do they have seats at the table? Or are they being empowered to bring their own chairs to the table to ensure that we deliver what we need for the nursing profession, the wider professional cohort of medical and health professions, and our patients?
As you were talking there, some of the things that, we're seeing lots of people are burning out, and it's, we're seeing it across the world. There's been some really interesting research by the Arch Collaborative run by CLASS, and they've associated some of that burnout with EPRs, and, clearly design of those EPRs is at the heart of some of that, and usability. We know people need training. But there is also documentation, and that mindset shift's a really interesting one. And I know I sound like I'm going off on a random tangent. It is linked with that well-being, because if we don't make our systems usable, we will add to their burden. But it's not just about the usable systems. It's about what we ask our profession to document and where we document. And that's the bit that is in our gift to control. The system will just present it all. And as nurses, we're really good. If there's a box, we'll try and fill it. We will tick every box. And technology will give you lots of choices and lots of boxes. And I think we've got to be really clear. This is what's needed here today. And how do you bring that in? Because then we can build systems that are usable. Because some of the CLASS evidence is suggesting that if nurses think they're doing more documentation, I think it's over 3 hours a week more than is actually warranted, or indeed makes a difference to patient care and the patient outcomes, they actually just don't see it as worthwhile. and they actually will blame their senior leaders of, you're adding to my burden. And I think that's something we've really got to pay attention to, because maybe it comes back to that comment earlier in the day of what can we control? Tech's not the only solution, is it? It's about how we design it, how we have a voice, but also what we put in there in the first place and how we guide it to make decisions.
I think there's also the case, Helen, that sort of if where space, where time is freed up, that actually we could, there is an element to saying we do need to think about our well-being, and actually it could make a difference to that, rather than just filling it with something else. It's not, I know there's, for us to be, if as good as we can at the job, it doesn't mean to say we've got to be busy, busy, busy all the time. And we actually need some thinking time, or some time for ourselves. And actually, can technology, free up some of that space, which we just don't have at the moment.
No, absolutely. I'm conscious of time and I don't know where this time has gone. I really don't. And what I'd like to hear is some points, what's resonated with each of you, from this conversation. What's the most important thing we need to be cognizant of as we move into the next age of digital and it becomes an AI era? What's the most important thing we as nurses need to think about and consider? Who wants to start? I'll open it up. I'll ask the question. I won't just point this time.
I'm happy to start.
Mm.
The most important thing to me is digital health technology and AI going to improve patient care? And is it going to improve their health outcomes? So I think unless it does, then we need to look at other approaches or solutions. Now, I'm sure it will help a lot in many ways, but not necessarily always. And it's a disruptive technology, and it's advancing so quickly. And the danger is we become so dependent or reliant on it and believe in it that we become sort of disciples rather than at times being healthily questioning of it, because we know that it can be inaccurate and it can make mistakes, and lives could depend on that. Not just from death, but quality of life and so on. So I think we've just got to be skeptical, healthily skeptical in a way, but see the potential benefits of it. But at the end of the day, it needs to improve patient care and health outcomes.
Absolutely. Love that.
Yeah.
Who's next?
I'll jump in next. So just following on from what David has said, my colleague Tendai is on the call, and she's the chair of the RCN Ophthalmic Nursing Forum and a clinical educator at UCL. And we currently have this ongoing discussion about the education of the ophthalmic nursing workforce and how do we train them to be critical thinkers and critical analysis. And I think that will also extend into the digital space. As David was saying, yes, the technologies are there. How much do we trust them? How much do we rely on our nursing judgment? And now, what is our nursing judgment actually based on? It's different from, when we used to use egg whites and oxygen to heal pressure ulcers. So who's generating the data? How is it generated? And how can it be used to safely administer nursing care? And where do we entwine AI and digital into that mix?
Wow. Yeah. Love the analogy of egg whites. Bridie, last but not least.
I'm going to pick up on Roxy's point, because the thing that strikes me is that it's not surprising. We've got to have evidence. We can be swept in with the movement. We need to embrace, we need to embrace new ideas, but we also need to be, picks up on what David said about being skeptical. We actually need to know that there's, what's the evidence to underpin it, because we wouldn't make, we wouldn't normally make decisions without having some evidence base behind it. And I think this is one where we need that evidence, and sad to say, we've got to have the funding to be able to do that. And so we need to make sure funding streams are targeted to allow the right sorts of research, the right sorts of evidence synthesis to take place.
totally agree. But we need to also publish our work and build that evidence base. I know we did some work looking at what nurse-led research had been done, looking at digital health technologies, and not a lot is the honest answer. So it's one of those things we push to the bottom of our list we haven't got time for, but it's one of those we always go back to the evidence. What is that? So it's so important. I have loved today's conversation. I have to say, you've sparked so many thoughts. I've been writing furiously. I might be a digital nurse, but I do think with a pen in my hand sometimes. You've talked about the power of collaboration, especially some of those international examples and what we can learn from different places across the world and how that can help us into the next era. The power of evidence and understanding data and how we using those to drive improvements to care. But at the heart of this is lots about teamwork, working in partnership. Co-productions come up a few times, whether it's with our workforce, whether it's with our citizens, and with our technical colleagues, working as a team to achieve a goal. But you've also put people at the heart of all of this. And I think, much as we might see a real challenge, I do absolutely believe the future is human, but it's also person-centered. I think digital could give us a real opportunity to make sure we personalize the care that makes a difference and we deliver it in a way that is right for them. But we'll only achieve that if we use our voice. And I think making sure we've got our voice in the right place at the right time, pushing our way through that table and making sure we speak and are heard, I think is going to be so important to make sure that we actually get what we need. As in the UK, nursing is the biggest profession of the workforce, with over 2% being nurses. And we have to be heard if we're really going to drive improvements, because we're at the heart of all of that. We are in this privileged position of supporting people through the most blessed of times and the most challenged of times. And it's how do we bring our role as advocates to really harness digital, not use our professionalism and use our professional judgment to really make sure we give great care with great outcomes. And David, you brought us back to outcomes. And I think that's the bit we need to come back to, isn't it? Is we can put in all the tech in the world. It's about how do we improve the quality of care and give people the outcomes so that they can add life to years, not years to life. Absolutely. I think that probably sums up that conversation, and fabulous, some real sparks. I'm going to go away and look at some research now, I think, which is lots of stuff in the background. So thank you to each of you for that such valuable conversation, and thank you to everybody that's listened and has contributed in the chat. There's been some great questions, and hopefully we've done justice to those questions gone along. Thanks to everybody who's planned and organised this event. There's been some great teamwork here from the RCN Library and Museum team and the Fellows representatives who've given their time as well. There is an evaluation form which you're going to get sent, so please do give feedback. But before I say goodnight for the evening, I'm going to hand you back to Daniel. Thank you.
Thank you so much, Helen, and it's been an amazing conversation. The time has just flown, so thank you for your time. I know you're a busy person, so thank
Delighted
you
to be
for
here.
coming along. Thank you to the fellows, of course, and as you say, thank you to the staff at the RCN who make all this possible. The event is recorded. It will be edited and uploaded to the RCN Fellows website. There's a page you can go to and follow this conversation again. I just want to finish by being really optimistic, I think, about what everybody has seen here in terms of opportunity. I think given today's world, we do need some sunshine and we do need some optimism, and I've certainly seen a lot of that tonight. So thank you, Bridie. Thank you, Roxanne. Thank you, David. And thank you very much, Helen.
Yeah,
And
thank you.
audience.
Thank you.
Good night. Thank you.
Thanks.
Good night. Have a good evening all.
Thanks a
Bye.
lot.
Bye.